Good evening, guys. I have B for you. Now, tonight's B, we are talking about clinicians. Okay, let them do the work they're trained to do. That is the title for tonight's B. Okay, here we go. The first time I met Linda, she was sitting in her kitchen table, at her kitchen table, sorting her medications into a plastic pill organizer. That had long ago lost its hinges. Outside her window, the fields were still frosted from the night before. Inside, the air was warm with the smell of coffee and the soft hum of the propane heater. She had driven 42 miles the day before to see her primary care doctor, only to learn he had left the practice. The clinic was down to a single part-time physician, and the next available appointment was weeks away. I don't need anything fancy, she said, sliding a tiny white pill into the Monday slot. I just need someone who can help me keep my blood pressure down. She already had that someone, the nurse practitioner who had cared for her for years. Who knew her history, who lived 10 minutes away, but state law required that the MP to practice under a physician who was no longer there. So Linda waited and worried and hoped her blood pressure wouldn't spike again. This is what scope of practice restrictions look like in real life. Not a policy debate, but a woman at her kitchen table trying to stay healthy in a system that keeps trying its own hands, tying its own hands. The rural workforce shortage is not a shortage of talent. It's a shortage of permission. In rural communities, the workforce crisis is not theoretical. It is lived. A single physician retirement a single physician retirement can leave an entire country or county without primary care. A maternity unit closure can force pregnant women to drive an hour for prenatal visits. A behavioral health vacancy can mean months long waits for therapy, and yet in these same communities we have nurse practitioners fully trained to diagnose, treat, and prescribe. Physician assistants already to staff emergency departments, pharmacists capable of managing chronic conditions, paramedics trained to deliver home based care, community health workers who know every back road, every family. The problem is not capability, it is outdated rules that prevent these clinicians from practicing at the top of their training. Guided link, NP full practice authority. Scope of expansion. Scope expansion is not a workaround. It's a rural survival strategy. In cities, scope debates can feel like abstract. In rural America, these are differences. They're different. They are different. They are the difference between care and no care. When we expand scopes of practice, patients get timely care instead of delayed care. Clinics stay open instead of closing. Chronic diseases are managed, not ignored. Emergency departments see fewer preventable crises. Communities retain local access instead of driving hours for basic services. This is not about replacing physicians. It is about building a team-based system where every clinician contributes fully. The evidence is clear, and rural communities already know it. Decades of research show that nurse practitioners and physician assistants provide safe, high quality care within expanded scopes. Pharmacists improve hypertension and diabetes control. Community paramedics reduce reduce unnecessary hospitalizations. Community health workers improve chronic disease outcomes and trust. But rural communities don't need academic studies to understand this. They see it every day. They see the they see the pharmacist who catches a dangerous drug interaction, the paramedic who checks on a homebound homebound elder, The nurse practitioner who stays in town long after the last physician leaves. These clinics are not extenders, they are the backbone of rural care. What, what stands in the way? Not safety, not quality, just outdated rules. Many scope of practice laws were written decades ago when training programs were different and telehealth barely existed. Today these laws function as barriers, not safeguards. They force they force rural clinicians to secure supervising supervising physicians who may live hours away, pay fees for overnight that adds no clinical value, delay care while waiting for signatures or approvals, limit services they are fully trained to provide. Meanwhile, patients like Linda wait and get sicker. A role ready model, the team that already exists. Imagine a rural county where a nurse practitioner leads the primary care clinic. A pharmacist adjusts medications and runs chronic disease programs. A community paramedic checks on high risk patients at home. A community, a community health worker ensures transportation, food, and broadband. A physician provides telehealth consults and monthly specialty clinics. This is not this is not a fancy uh, this is not a fantasy. It is happening in pockets across the country and it works. Community paramedicine. Just a second, guys. My papers are stuck here. The moral arrangements or the moral argument. Trust rural communities to know what works for them. Rural America is tired of being told what what it cannot do, tired of being asked to wait for clinicians who will never come, tired of policies written for cities and applied everywhere else. Scope expansion is not deregulation. It is right-sized regulation to match reality. It is trusting rural clinicians, trusting rural patients, trusting rural communities to know what they need. The call to action. If we want a healthier rural America, we must modernize scope practice laws, remove unnecessary supervisory requirements, align reimbursement with team-based care, invest in rural training pipelines, support telehealth and home-based care models, because the truth is simple. Rural communities cannot wait for a perfect workforce pipeline. They need a system that works now. Linda eventually got her blood pressure under control, but only after weeks of delay that never should have happened. No patient should have to wait for care when a trained clinician is right there, ready to help. Let rural, rural clinicians do the work they are trained to do. Let rural communities build the care systems they deserve. Let scope expansion be the tool that finally closes the distance between illness and care. Okay, guys, that is your B for tonight. I will, depending on time, I will try and do another show, which will be discussion C. If I get a second or two, let me take a little break and I'll see if I can do one more show for y'all. For now, Gator Wellness, take care, folks.